for joining us. Today we will be presenting on our proposal for a pediatric patient-centered medical home. Our agenda for today is as follows. We are going to go over the organizational overview, the strategic planning process, the operations and implementations, the financial impact of our proposal, and then we will conclude with a short recap. We want to start off by sharing with you the mission of the Greater Los Angeles Valley Children's Center, which we will from now on be referring to as GLAVC. They are committed to the health and well-being of their patients while providing quality, comprehensive care to their pediatric population while keeping the family's needs in mind. Some current challenges that GLAVC are facing are their rising expenditures, their high ED utilization rate, which has increased by a little over 10% from 2011 to 2012, their low ambulatory care center utilization, which has decreased in outpatient visits by a little over 5% from 2011 to 2012, and their 15% self-payer mix. After looking at the demographic profile for the Riverside community, we found that many of the population were either Medi-Cal or Medi-Cal eligible, thus referring that this 15% self-pay that is using the emergency room are not people using care that can come in and pay out of pocket, but people who are not able to pay at all, thus resulting in some high uncompensated care costs. To start the strategic planning process, we looked over the 4 proposed alternatives: mergers and acquisitions, development of an ACO, the pediatric specialty health plan, and finally testing a value-based care model. In order to effectively choose the strategic response for GLAVC, we used a factor method and found 5 criteria that GLAVC needed to address. We weighed each of these criteria on a scale of 1 to 10, with 1 being the least favorable and 10 being the most favorable. We started off by looking at merger and acquisitions, and we saw that although this would relieve some of the financial burden off of GLAVC, it wouldn't really address their high ED utilization, and it wouldn't really help in the timeliness that GLAVC needed. We then looked at the specialty health plan and saw that it would help with cost savings, but it may not really address their ED utilization, and they also did not have the capital requirements for reserve that you need to start a health plan. We really liked the idea of an ACO because we knew it would help with the cost savings as well as decreasing the high ED utilization. However, in looking further into it, we saw that it costs around $1.7 million just for startup costs, which GLAVC currently doesn't have. It also took around 3 to 5 years for implementation, and they did not meet the requirements per CMS for the patient panel size. In looking at testing value-based care models, we really liked this for GLAVC because it would simultaneously address their high ED utilization as well as their high expenses. It could also be done in a timely manner, and it wouldn't require much capital. After looking at all of them together, we felt that testing value-based care models was going to be their best strategic response. California is already making the move towards managed care, so we felt like this was a step in the right direction. It could also be a crawl-before-you-walk scenario to test this out for 3 to 5 years and maybe eventually look into starting up their own ACO. In moving forward with our strategic response, we are proposing that GLAVC start a pediatric patient-centered medical home called Children's Choice. We have all seen the numerous headlines on TV, in the news, and on the web, addressing the high healthcare costs and how it is affecting our nation. Let's take, for example, Sean, who is an 8-year-old boy living in Riverside County. His mother is a teacher, and his father is in construction. Sean has severe asthma with no insurance, even though he is Medi-Cal eligible. He has no primary care physician, therefore, anytime he utilizes healthcare services, they are not properly tracked or recorded, and he has no follow-up visits in his plan of care. Anytime Sean has an asthma attack or severe chest pain, he is taken to the emergency department immediately, where his family is unable to pay for those care, thus resulting in higher uncompensated costs. In order to address this lapse in care for Sean, we are proposing that Children's Choice use the NCQA 7 elements for starting up a PCMH. First and foremost, it must be team-based, have care coordination, provide preventative care and continuum of care, patient empowerment, IT integration, and population management. By using these 7 different elements, this can help to reduce some of the burden off of the ED department and move many of these non-emergent cases to outpatient visits. In looking at the Riverside Community Health Profile, we identified 2 health indicators that we wanted to address through Children's Choice, one of those being obesity. The percent of children that were obese in Riverside were higher than those in the state of California. The second health indicator we want Children's Choice to address are the number of patients that are coming into the emergency department with asthma. Although these ED visits in Riverside are lower than those in the state of California, they are still substantially higher than those in the surrounding counties and are also very costly to the emergency department when many of these cases are non-emergent. Wellness and prevention is a big part of Children's Choice. We want to be proactive in the patient's health care instead of reactive. We saw that many teens in Riverside County are uncomfortable talking to their pediatrician about their physical activity and their nutrition. Through Children's Choice, we would be able to provide these children with a primary care doctor that they could begin to establish a relationship with and open up those lines of communications. Another big part of prevention is vaccinations. We saw that under 40% of our children in GLAFC and Riverside community are vaccinated. This is lower than the state of California and substantially lower than the nation's goal for Healthy People 2020. In order to properly provide this continuum of care, we are proposing that GLAFC partner with Riverside Medical Clinic, a group of 6 medical clinics dispersed throughout the Riverside County. They have 3 urgent care clinics and 15 pediatricians throughout. They also have a great reputation of developing quality care. Some incentives for RMC to partner with GLAFC are the shared savings they would gain from the continuum of care as well as the managed care dollars that Rendell will be discussing further. They would have minimal risk, and GLAFC would provide the financial and administrative background to get them NCQA accredited. This would also help in bolstering their medical home, and this would give them integrated access to GLAFC's NICU, PICU, emergent services, and all inpatient acute services. Some improvements to GLAFC's organizational structure will be the 2 care coordinators, an enrollment specialist, a 24/7 nurse call line, and their increased operational hours to their ambulatory care center. In looking at our proposal, we address some of the key stakeholders. First and foremost, it's the patient and their families. We want the patients to be better engaged and better in charge of their health. GLAFC will provide the financial and administrative costs to the NCQA accreditation as well as the clinical integration needed. Riverside Medical Group will provide the 5 sites for Children's Choice as well as preventative care, continuum of care, and primary care. Payers such as Medi-Cal will help in improving incentives and the structure of payment for doctors to provide that quality care needed. Other clinicians will have increased responsibilities, workflow changes, and an increased use of nurse practitioners and PAs. The quality department will help in finding and collecting data and sharing that information in order to better improve quality and develop evidence-based guidelines. And finally, the County of Riverside Department of Public Health will create and support any initiatives for quality improvement, especially those aligned with the Healthy Riverside initiatives that are already in place in California now. Now Ashley will begin to discuss the operations and implementations of our proposal.
Developing an executive dashboard is an important part in evaluating the performance of the proposed strategy that Vanessa just described. We recommend developing metrics based on operational efficiency, quality improvement, and financial viability. The backbone of Children's Choice is utilizing information technology. In order to be NCQA PCMH accredited, at least 10% of patients must have electronic access to their health records. We plan on not only meeting that standard, but taking it one step further and tracking the number of patients who are actually accessing the portal. A higher percentage for this metric would suggest that the more patients use the patient portal, the less time providers have to do those same things by phone. We expect our patient panel size to be 27,923 in year 1, increasing to 28,148 by year 2, and to 28,261 by year 3. These numbers are based on the projected proportion of the new 75,000 Medi-Cal enrollees transitioning from California's CHIP program, Healthy Families, that GLAFC will be able to capture, along with our ability to market to Riverside Medical Clinic patients. Our quality metrics focus on care outcomes. Based on our research, we found that most of the obese, overweight population is Medicaid patients. Therefore, we want to decrease the prevalence of obesity in students by 2.5% each year to align with the objectives of First Lady Obama's Let's Move campaign. We also anticipate a 50% decrease in asthma-related ED visits over the course of 5 years in order to bridge the gap in the lapse of continuity of care. Lastly, we project a 10% increase in yearly WellCare visits to PCPs in order to align with the outcomes we saw in the other PCMH models that we studied. Finally, for our financial metrics, we want to focus on self-pay as a percent of payer source. As Vanessa mentioned, GLAFC currently has a 15% self-pay mix. These are the individuals that are Medi-Cal eligible but do not enroll. According to Becker's Hospital Review, the national benchmark for self-pay patients is 5%. Given that GLAFC would need some time to incrementally decrease their self-pay mix, we realistically expect them to decrease it by 2.5% each year. Now I would discuss the PCMH model we expect GLAFC and RMC to employ. We recommend using a two-pronged approach in identifying and capturing patients to enter our initiative. One way is if a child enters the ED with a non-emergent case and then is triaged, the ED clerk will provide him with a Children's Choice brochure and outline the benefits of Children's Choice. These can also be referenced in your appendices. We recognize that 40.6% of GLAFC's population is Hispanic, so we will also provide the brochure in Spanish as well. The ED clerk will then make a note in the patient's records indicating that they've been made aware of Children's Choice. The enrollment specialist will then receive notification through the EHR that there is a potential new Medi-Cal enrollee. It will be his or her responsibility to actively follow up with that child and their family to ensure consistent insurance coverage, even if that means going to the ED waiting room and walking them through the application process. Another way we will capture patients is by identifying high-risk individuals through the disease registries at Riverside Medical Clinic and identifying those high utilizers of their services. So once we are able to identify and capture our patients, how do we keep them aligned with the patient-centered goals we are trying to pursue through Children's Choice? Let's revisit the story of Sean and see how our proposed model will help him and other kids in Riverside with asthma conditions. Once Sean is enrolled, his assigned care coordinator will track his care utilization to ensure it's being accessed at the right time and at the right place. His assigned care coordinator will help set up his first PCP visit, where he is able to engage in those crucial conversations with his PCP regarding healthy weight, nutrition, and physical activity. If and when Sean experiences asthma problems, his parents will have access to a nurse call line where they can schedule a next day visit or to get advice on the appropriate level of care to seek. Within Children's Choice, RMC will utilize developed protocols to ensure an evidence-based bundle of care. And finally, Sean and his family will have access to his medical records and his asthma care regimen through the patient portal, which is going to be interoperable between GLAFC and RMC. At its core, Children's Choice is a team-based approach to care with many intertwining relationships. Therefore, buy-in from different stakeholders is key for its proposed success. In order to facilitate that buy-in, we recommend using a centralized steering committee comprised of physicians, nurse coordinators, care coordinators, and IT specialists. These are the individuals that help manage the flow of information and get the ball rolling on the project. Next, we recommend identifying and using a physician champion as someone who can advocate the values of Children's Choice to other physicians and to the practice team. And finally, we recommend conducting regular employee satisfaction surveys as a way to engage the employees in the transformation that is occurring. Riddell will now conclude with the financial analysis of our proposed model.
So before I go into the different operating budgets, I first wanted to highlight our two main sources of cost savings that we've identified within our proposal. First, we have the reduction in our ED utilization as a direct result of our Children's Choice PCMH, the nurse call line, the increase in our ambulatory care center hours. Second, we have the decrease in self-pay patients, which we've correlated with our uncompensated care. I will now go over our different operating budgets for each of our initiatives. First, I'll discuss our managed care Medi-Cal model, our Children's Choice PCMH and nurse call line, the increase in ambulatory care center hours, and then finally, the decrease in our self-pay patients. Our proposed value-based care model is that of managed care coupled with capitation. Rather than fee-for-service, financing on per member per month requires improved health outcomes while staying within a consistent cost-contained budget. To finance the care for our Children's Choice PCMH patient panel, GLAFC will negotiate a set rate per member per month with managed care Medi-Cal. With those managed care dollars, GLAFC will then subcontract with RMC by capitation to provide those primary care services. GLAFC will then retain a certain percentage of those managed care dollars to finance the inpatient and emergency care, as well as the administrative expenses behind the Children's Choice PCMH. Should the relationship between GLAFC and RMC truly result in healthier outcomes, future modifications to their partnership can be made, such as a catastrophic cap to protect RMC from exorbitant charges from the cost of care. as well as a pay-for-performance incentive that will further encourage improved health outcomes. Here's a closer look at our managed care finances. First, we've estimated the total cost of emergency care for our Medi-Cal patients. From that number, GLAFC will then negotiate an 80% reimbursement from managed care Medi-Cal in accordance to Medicaid rates. Expenses incurred from this initiative will be 70% capitation for RMC, and we've estimated that 25% will fund our inpatient and emergency care. When considering our managed care funds and the total expenses incurred, we estimated that GLAFC will be able to retain 5% of those managed care funds. Over 3 years, we've calculated that they will be able to retain $3.2 million in revenue. With our Children's Choice PCMH and our nurse call line, our studies have shown that we will be able to decrease our ED utilization within our Children's Choice patient panel by 7.75% each year. This decrease in utilization will thus result in a decrease in our revenues and expenses. Over time, as you can see, the gap between our revenues and expenses will get smaller. The expenses incurred from this initiative are from hiring of extra staff, which are our 2 care coordinators, our enrollment specialist, and our advice nurse. To calculate our anticipated cost savings, we compared our cost incurred without the initiative with the cost incurred with our initiative. Due to the hiring of our extra staff, you can see that we actually end up incurring an additional expense of $591,000. However, we don't see this as simply as an expense, but rather an investment in our Children's Choice patient panel. By increasing our ambulatory care center hours, our studies have shown we will be able to decrease our ED utilization by 1.33%. Again, this decrease in utilization will thus result in a decrease in our revenues and expenses, which again, the gap between our revenues and expenses will decrease over time. The expenses incurred from this initiative will be that of the extra hours with our operating expenses. By increasing our ambulatory care center hours, our anticipated total cost savings over 3 years is $76,000. And finally, by decreasing our self-pay patients in accordance with our financial metrics that Ashley discussed earlier, we seek to decrease that percentage by 2.5% each year. By decreasing our self-pay patient population, we are opening a new source of revenue. Over 3 years, we've calculated that revenue to be over $95,000. With our 4 initiatives combined, although we see that we do in fact incur an additional 514 expenses, we do see that we are able to open up a new source of revenue amounting to $3.3 million. In conclusion, now that we've covered the operational, strategic, and financial aspects of our proposal, we hope that we've been able to convey that we've wanted to stay within the parameters of GLAFC's mission, but also to bring back the value in healthcare. From our Children's Choice PCMH, our nurse call line, the increase in our ambulatory care hours, and seeking to secure coverage for our patients, all of our initiatives are truly centered around improving our healthcare outcomes for our patients and improving the experience for the patients and their families. At the end of the day, as healthcare professionals, our decisions must also be centered by our patients and their families. We thank you for your time and now open the floor for questions.
Good evening. I'm sorry. Thank you very much for your presentation. I have a question about your estimated expenses for your care coordinators and enrollment specialists. You have a patient panel of 28,000 expected patients in the first year, but yet you have 2 care coordinators. Did you benchmark what's needed?
Well, right now, most of the patients would, with the transition from Medi-Cal, the transition from Healthy Families into Medi-Cal, most of those patients will already have a relationship with their PCPs, so we found that as a way for us to decrease the amount of care coordinators that we will initially need.
In reference to follow up with that, so we were going to add 2 staff members.
Mm-hmm.
You're going to decrease the ED visits with your Medi-Cal patients. Tell me how you connect the staff, because you're not going to have as many visits, and I didn't hear where staffing was addressed in the ED to accommodate for the decrease in ED volume.
Mm-hmm.
And why not just pull from the staff from the ED with the minimal volume, with the decrease in volume, and pull those over to the ambulatory care, as opposed to just hiring 2 people? So address the staffing issues is my question.
Well, I think that's not out of the question. I mean, should we see someone that would be able to fulfill these needs in those areas, then we would be more than open to that. However, we just wanted to make sure that we were able to show it as line items. We didn't just want to assume that people would be transitioning out of this place and going here. So we just wanted to make sure that you were able to see that that's kind of how our thought process went. But we're by no means closing it off to that kind of alternative.
But address the staffing issues, because you're gonna decrease volume, but you didn't address making any staffing adjustments with the decrease in your ED volume at Glass.
With looking at the finances, we saw that a lot of the staffing came out of the ED, and we assumed with the volume decreasing, but we kind of factored that into our operating expense, the staffing decreasing by that because of the reduced volume. It was within the operating expenses.
Okay.
Thank you for taking a systematic approach to evaluating the options. My question is, as we look at, and you're weighting the cost, you called it the cost savings, did you actually analyze each of the options? Did you break down the cost of each one to rate them? Or was that an anecdotal rating for each one of those?
We didn't necessarily break down the entire cost of each, but in doing research and seeing other organizations who have implemented those types of strategic responses, such as like the ACO in that area, the average cost was the $1.7 million just to start it up, which is the money they didn't have. For the specialty health plan, we didn't look much into it just because the capital reserve requirement we knew was pretty high, and because of the financial crisis that GLAVC is currently in, we didn't want to put them in more crisis by putting that reserve away, and then this may not be working out for them.
Okay. And then secondly, your projections for the patient panel, what were the assumptions that you used to come up with those 3-year projections?
We based it on 3 different criteria. One, we looked at the emergency department visits, and we got those numbers from accounting for the frequent flyer percentage that would happen. So we found, based on our research, that frequent flyers were about 16.5% of ED visits. So we calculated that, and then we took into account the Medi-Cal population within that cohort and reduced that down to 2,578. And then we were trying to have a decrease in ED utilization by 2.5% each year. So we staggered that out for the 3 different years. Then we also took into account the number of patients that RMC has. And based on our research, we found that they have a 250,000 active patient panel. And from those, we calculated that the pediatric population within those 250,000 is 27.4%. So from there, then we also used the Medi-Cal and the percent of Medicaid patients within that cohort and found that number. And
So you're going to only focus on your current patient population. Are you reaching out to the market potential that's out there to look at other patients that might offset the patients who are frequent users?
Yes, with the transition from California's CHIP program into Medi-Cal, we took into account those number of patients and our ability to market to other patients within the surrounding counties.
Okay, thank you.
So I just have a couple of questions just about kind of the practicality of some of the pieces that you have presented. So I like the strategy of having enrollment specialists, especially walking families through the application process. One is, did you think about the enrollment specialists or what the position description would be around that? Would they need to be bilingual or?
Yes, that's something we definitely would want to have as we are handing out brochures that are, Spanish and English. We want that to happen.
And then also, when you have an enrollment specialist, have you thought about just kind of the physical location, and would there be a need for restructuring the physical, the physical location in space to avoid any HIPAA violations when you have these enrollment specialists speaking with families?
Well, I think we wanted to say that when they come into the emergency room, they'll be able to have access to an enrollment specialist, but we realize they can't just sit there and have that conversation. But I think that's where the ED clerk comes in and is like, well, here's the brochure. If you need someone to contact, here's that person. Then as Ashley stated, the EHR will be able to alert the enrollment specialist of that patient, so they'll be able to reach out also through that. I think we're trying to integrate all of the different pieces to be able to inform everyone involved that there's a potential person that we can cover.
Could you articulate a couple of your strategies for increasing use of the patient portal and achieving your quality metrics?
Yes. So for our patient portal, one of the main reasons why we wanted to partner with Riverside Medical Clinic is because they actually have a patient portal that's already in use. So we will be able to have that interoperable between RMC and GLAFC as well. And so we'll be able to educate, most of our patients that we are trying to attract will kind of already have that knowledge of it because they are familiar with it as well. And then your second question pertained to?
Yeah, you also got some quality improvements with your asthma reduction and your ED visits.
Well, most of that's going to happen through the relationship that the patient will have with their PCP and be able to engage in those really crucial conversations that they need to have with them, and the care coordinator being able to track that utilization of care throughout the process and to ensure that they're following their care regimen.
And also the access to the nurse call line, so that parents do have that option to call and see if it is something that's emergent that they do need to take in, or if it's something that can be scheduled the next day or the following week with the primary care physician.
Thank you.
Your per member per month payment, what was that going to cover? I mean, how comprehensive was that going to be? Is that inpatient, outpatient? What does it cover?
For us, we kind of projected that number from the emergency care visits, but the way that we doled it out was kind of covering all of that. We had the capitation to RMC, and then we covered the inpatient and emergency care. But we kept a lot of the numbers really conservative because we didn't want to shoot for the stars and fall short. We just really wanted to keep a realistic amount. And then with the capitating of RMC, RMC really is going to have to take that money and learn and be able to navigate that and be able to parse it out the way that they can, because that's kind of how their arrangement's going to be with RMC.
So it covers both?
Mm-hmm.
Okay. And the pay for performance, how would that, what was the idea there?
The idea would be with shared savings. If RMC falls below that 70% and then they see that they have that extra, they can keep that. And then with GLAFC on their end, if they see that the patients coming to their ED or inpatient and emergency care services are they're not as cost consuming, then they can share the savings between the two of them of the managed care. And I think we didn't want to go beyond that because we didn't want to presume a relationship that results in that. But I mean, in the future, once that margin between the managed care funds and the capitation and the cost of care, they'll be able to share that savings.
Mm-hmm.